So this is the April 2024 MEC Minute, and today we're going to talk about vascular emergencies. And these are things you really don't want to miss, or these are things you should keep in your mind as possible causes of patient symptoms when you see them. All these can be life or limb threatening if not promptly identified. And everything you do makes a difference in terms of patient outcomes. So if you have a high level suspicion, you can notify the receiving facility and they can be prepared to evaluate the patient. So let's start with three cases, and we're going to talk about them here. I want you to think about these three cases, and then we'll talk about them again at the end. So first is a 45-year-old female complaint of acute left eye discomfort with a droopy eyelid, a mild headache, and some mild right arm weakness. Second is a 30-year-old male with a known history of Marfan's disease. We'll talk about Marfan's in a moment, with acute chest pain radiating to the interscapular area and bloody diarrhea. And case number three is a 75-year-old female with severe abdominal pain, irregular pulse, and minimal abdominal tenderness. Keep all these three cases in mind as we go through this. So what are we going to talk about? We're going to talk about a carotid dissection. We're going to talk about aortic dissections. We're going to talk about abdominal aortic aneurysms. We're going to talk some about acute mesenteric ischemia, and we'll talk about acute arterial occlusion, particularly of the extremities. So keep these in mind. So first off, I told you we were going to talk about Marfan's. What is Marfan's? Well, Marfan's is an inherited connective tissue disorder. And the connective tissue just not as strong, and it can affect the heart. It can affect the eyes. The eyes can actually develop lens dislocations because the connective tissue that holds the lens of the eye in place don't function properly. It can affect blood vessels and the skeleton. And when we talk about blood vessels, we're talking about particularly blood vessels where you can have bad outcomes. So two of the five things we're going to talk about, Marfan's is a risk factor to develop. These patients typically are tall, thin, with long arms, legs, and fingers. And if the aorta is involved, it can become life-threatening. You can have a dilatation of the aorta, you can develop a thoracic aortic aneurysm, and all the associated complications, which would include aortic valve disease and so on. So typically patients with Marfan's syndrome are monitored very closely, and if they have evidence of significant aortic dilatation, they'll have prophylactic surgery with stent and or aortic valve replacement. On the right-hand side, you've got some graphics. You can see patients tend to have flat feet. They have very long fingers. They can actually wrap fingers around their wrists. If you look at them, their arm span, if they put their arms out left to right, their arm span is greater if you measure it than their physical height. So their arm span might be 6 feet, their height may be 5 feet 8 inches, just an example. They can have some trouble extending the elbows. They may have scoliosis. So if you look at their back, they have an S-shaped pattern to their back. I'm not suggesting you pull somebody's shirt up in the field, but if you hear about it, you'll know. Their face tends to be long and narrow, and so on. And again, if you look at the patients, have them stretch their arms out, their arm span is greater than their height. So it's something you can pretty much tell. You don't necessarily have to put the patient up against the wall and measure them. If you haven't put their arms out, compare that to the height, you get a pretty good idea just by looking at the patients. And if you look at what the fingers, the thumbs tend to be very long. One of the things you can do is have them put their thumb out to the toward the fifth finger and fold their fingers over like they're making a fist over the thumb, and the thumb sticks out. The other is if they take their thumb and their index finger, it'll actually wrap around the wrist. These are all screening tools you can use to evaluate for Marfan's. Well, why is this a concern? Well, the first thing we're going to talk about is carotid dissections, which is a tear in the inner layer of the carotid artery, and that tear causes dissection through the tissues of the artery, and you get a false channel where blood can go. And you can get carotid dissections from penetrating injuries, a gunshot wound to the neck, or stab wound to the neck, or blunt trauma to the neck, which is why patients who are strangled will often do a CT angiogram of the neck to look for a carotid dissection. Or, as in what we're talking about today, it can occur spontaneously. It just happens. Risk factors include Marfan's disease or other connective tissue diseases like Ehlers-Danlos syndrome, and carotid dissections can account for about 2.5% of all the strokes that we see. So what kind of symptoms might you see with a dissection? Well, you can have headache, facial pain, eye pain, neck pain, visual changes. You can have symptoms of stroke. It's like I mentioned, 2.5% of these patients, of stroke patients, end up with a carotid dissection as the causative etiology. And there's something called Horner syndrome you may see. And on the left-hand side, if you look at the gentleman's left eye or the eye on your right, you'll see evidence of Horner syndrome. Horner syndrome is a small pupil compared to the other pupil, so the affected side of the pupil is small. You can see some droopy eyelid, and actually they talk about decreased sweating under the eye. Honestly, patients I've seen with Horner syndrome, there's no way for me to effectively test for sweating. But you could also see an eyeball that seems to be recessed back in the socket. So that's what a Horner syndrome is. So if you see a patient with some of the symptoms like I mentioned, and you notice a Horner syndrome, carotid dissection is a concern. And again, it could also be a concern because of traumatic dissection like strangulation. Complications of the carotid dissections are they're high risk for stroke or bleeding, and you need to think about this whenever you're entertaining the thoughts of possible stroke. And we diagnose this with either a CT angiogram or MR angiogram. Typically, in the emergency department, it's much easier to do a CT angiogram than an MRI. And the treatment is either stenting or anticoagulation. For whatever reason, anticoagulation it seems to be the means of choice to treat this. Occasionally, these defects will be stented. Majority of them do not require stenting, but we do get the vascular surgeons involved. So from an imaging perspective, what might this look like? So here we have a CT for the photo on the left. When you look at it, what's on your right is the patient's left-hand side, and you can see that big round white spot, which is labeled with a red arrow, says normal internal carotid artery. If you look at the same spot on the left side, you can see just a little bit of dye, and then you see this dark spot right next to it, and that dark spot is the hematoma in the carotid wall. If you look on the right-hand side, the yellow arrow shows a black line, which is actually the tear in the carotid artery. It's the takeoff point for the dissection. And if you look at the top of that carotid artery where the red arrow is, that's actually evidence of occlusion of the lumen or opening of the carotid. So there's actually physical blockage there because of that dissection. So this is an example of a carotid dissection. An aortic dissection, we're going to talk about aortic dissection, which is a tear in the wall of the aorta with a false channel being caused by that tear. That's a dissection versus an aneurysm with rupture, which is what we think about in the abdominal aorta. That's a different item we'll talk about in a few minutes. But an aortic dissection is a tear in the inner layer of the aorta. Blood then dissects between the layers of the aortic wall. It forms a false channel, and that false channel can actually swell to the point where it includes blood outflow, or it could actually rupture to the outside of the blood vessel and become basically a cause of death from exsanguination. Aortic dissections can be due to trauma, again, blunt or penetrating, or can also occur spontaneously. The number one risk factor for aortic dissection is hypertension, particularly uncontrolled hypertension. The second most common risk factor is Marfan's disease, like we talked about earlier, or other connective tissue diseases like Ehlers-Danlos syndrome. Smoking and cocaine use can also lead to aortic dissection or increase your risk. A bicuspid or two leaflet aortic valve can cause aortic dissections. Most or normal aortic valves have three parts to it, three leaflets, three flaps. A bicuspid aortic valve has two flaps, and that also increases risk for aortic dissection as well as infection of the valve with endocarditis. And then an aortic aneurysm can actually go up far enough and that it can become an aortic dissection. So what kind of symptoms might you have? You can have acute onset of tearing, stabbing pain, or pain in the upper back between the scapulas, or you can have pain that radiates from one area to the other. It's often abrupt in onset. You could have symptoms of MI or STEMI on an ECG if this dissection is in such a location that it blocks or occludes one of the two coronary arteries. You can have evidence of a STEMI because of the blockage from the dissection, not because there is a acute blockage in the coronary artery. Typically, these patients have severe pain, but they can also have a syncopal episode. They can have symptoms related to stroke. So if you have a dissection of the aorta as it's coming out of the heart, it can actually clip off one or two of the blood vessels to the vein, just like it can clip off one of the coronary arteries, and you can have stroke symptoms as related to the area of distribution for that artery. And if it's severe enough, this dissection goes all the way down the aorta. It can occlude the blood vessels that go to the gut, and you can have symptoms of ischemic gut like abdominal pain or bloody diarrhea, things like that. The complications, it's a high aortic dissection. Untreated, it has a high risk for death and organ damage. Which organs are damaged depends on where the dissection is. Our diagnosis really needs to start with the suspicion. Acute onset of severe pain that starts in the chest and goes into the upper back, that's a dissection until proven otherwise. You may notice a blood pressure difference between the arms. So depending on where the aneurysm is or the dissection is, you could have a normal blood pressure in the right arm, but an abnormal blood pressure in the left arm, just because you have decreased outflow and the blood vessel to the left arm is impaired. You can have cool or cold appearing limbs. And on chest x-ray, you could see a wide mediastinum or wide heart silhouette. We could do an ultrasound of the heart or echocardiogram. But if we're really worried about aortic dissection in the emergency department, we're going to do a CT angiogram. They're quick, they're easy. Occasionally, we have a patient with a contrast dye allergy, and we have to do an MR. That's not very common, and it takes much more time. So our preference is if we have a consideration for dissection, we get a CT angiogram. Here's some anatomy. So you have this big candy cane-like structure coming out of the heart. You'll see the valves at the bottom of the tip of the candy cane, and you can see the black areas, which are a diagrammatic illustration of the area of dissection. In the past, we used the DeBakey criteria. It's much easier to use type A, type B. Type A aortic dissection starts at the aortic root and works its way around, whereas a type B dissection starts away from the aortic root and works its way down. So it may not really be that important for you, but it's important to us in the emergency department because how we treat this condition depends on where the dissection is. For all of our patients in the emergency department, we treat patients' blood pressure and pulse rate. So if these patients are hypertensive, we'll give them a beta blocker to slow the heart rate down. We'll give them a nitroglycerin or nitroprusside to reduce their blood pressure. So we want to get their blood pressure down so there's not as much damage being formed or caused to the aorta through the dissection. If it's a type A dissection, then we typically go to surgery. If it's a type B, typically it's treated with medical management and ongoing hypertension control, sometimes required surgery. And for all these patients, we'll treat the complications as they come. More graphics. So if you look at these chest CTs, the one on the left is cutting the body crosswise. The one in the middle is kind of cutting the body from the top to bottom, but going left to right. And on the right-hand side, we see a side view. And all of these, you see a dark black line highlighted by a red arrow. That is the dissection. That is the flap of aorta. And now you have blood on both sides. So this is probably a type A dissection. It starts at the proximal aorta near the aortic root and wraps its way around almost down into the abdominal component of the aorta. Moving on to talk about the aorta, we'll talk about abdominal aortic aneurysm. Typically, these are in the abdominal aorta. It's an enlargement of the abdominal aorta. It's typically something that develops over time. It is not a dissection. A dissection is an acute event. An abdominal aortic aneurysm is an event that forms over time. Hypertension is a significant risk factor, as is hyperlipidemia and atherosclerosis. Again, no good things about smoking. Smoking is a risk factor for aneurysm, and there tends to be a fairly strong family history. Symptoms usually are lacking until there's rupture, although sometimes as these aneurysms get bigger, you may cause some back and abdominal pain or chest pain just because of the physical size of the aneurysm. Patients may notice a pulsatile mass. Sometimes the patients have a syncopal episode as the aneurysm rapidly expands or starts to leak. I've had a couple patients over the years who told me they've had aliens growing in their abdomen, and if you feel their belly, it's this big pulsatile aneurysm. These patients are at high risk for death on rupture. So if these aneurysms rupture, patient is at very high risk, well over 80% chance of dying. We have to have suspicion based upon symptoms and risk factors. We have to examine the patient. And in the emergency department, we're going to get either a quick ultrasound or a quick CT or CT angiogram. Ultrasounds are very quick, very easy. You can have one done in 5 minutes. And really what we're doing is looking to see if there's an aneurysm so we get vascular surgery inbound. We can do any additional imaging after that. So the key factor here is doing something quick and easy to get a diagnosis. Here are some images for you. On the left-hand side is an image of the aorta with ultrasound. You can see the red arrows identifying the size of the aneurysm. On the left side, you see a dark area. That's what's left of the lumen of the aneurysm. That's where blood is flowing through. And on the right-hand side, you see that grayish material. That's the blood clot within the aneurysm or the thrombus. And you can see that C-shaped crescent white shadow at the bottom. That's the spinous or one of the vertebrae of the spine. So we use that to help localize the location of the aorta. If you look at the central image, it's a CT, and you see the one arrow with the hollow tip. That is the aneurysm. That's pretty big. And if you see the solid white arrow in the bottom right part of that image, that is blood that's leaking into the retroperitoneal space. And then on the right-hand side, you see an aneurysm that's had a stent placed, and the blue line going around it shows the outline of the aneurysm that's present. The stent is there, which goes right through the aneurysm, pretty much occluding it, so blood flows through the stent and bypasses the aneurysm. So how do we treat abdominal aortic aneurysm? So like I mentioned, in the ED, it's rapid identification. If the patient's hypotensive, we start blood products. We get early surgical evaluation and consult because if it's daytime, vascular surgery is around. If it's nighttime, it's going to take them 20, 30 minutes to get in. And if they know they've got an aneurysm and the patient's in trouble, they'll have the OR inbound at the same time they're coming in. Typically, we get these patients in the OR 30 to 40 minutes after we reach out to vascular surgery. For the surgeon, there's the question, do they do an open case where they open up the abdomen surgically and put a graft in that way, or do they go in from the groin and put a stent in via endovascular repair? These days, most of these aneurysms are done endovascularly. It's quicker. It's easier to stabilize the patient during surgery. If you open a patient up, as soon as you start going into the abdomen, you're at risk for blood to leak out, and blood that may have been tamponaded now can go everywhere. And it's much easier for the patient to bleed out with an open procedure. Rarely are aneurysms managed medically. Typically, it's in patients who have significant morbidities or comorbidities, or patients who do not want any heroics completed. Those patients typically get medical management and consultation to palliative care. If the patient's asymptomatic, we observe them. Vascular surgery, typically we'll watch them when the aneurysm gets to 4.5, 5 centimeters. They'll start talking about doing a repair. Do it under controlled circumstances where there's best outcome for the patients. And these days, with our current technique, elective repair of an asymptomatic aneurysm is generally very successful, and patients do very well. One item that we need to always be aware of is something called acute mesenteric ischemia. That's where you have dying or dead gut. And if you look at this picture, the healthy gut is that pink material. The purple gut, that's dead or dying gut. That's going to need to be either removed or have flow restored to it. So what we're talking about is portions of the gut that have acute occlusion of one of the 3 blood vessels to the gut. And because of that occlusion, the gut becomes ischemic. And about 50% of these cases of mesenteric ischemia are embolic in origin to one of the 3 arteries called the superior mesenteric, meaning like a stroke, a blood clot drifts from somewhere, typically the heart, goes to an organ, cuts off the blood supply, and then the patient has symptoms related to that ischemia. The patients with acute mesenteric ischemia involving the superior mesenteric artery, or the SMA, though about 50% of those patients are going to die. If you look at all of our patients with ischemia of the gut, about 10% of the cases are venous. The overall mortality is 60 to 80%. Most of these patients are elderly. Most of them have 3 or more chronic medical conditions that increase their risk of dying. So acute mesenteric ischemia is has a high fatality rate, and the way we can reduce that fatality rate is by having early suspicion. So what things might make us think about it? Well, risk factors for atrial fibrillation or cardiac disease or prosthetic aortic valves, bad heart valve. Those are all risk factors for blood clot formation that can then become embolic and cause these symptoms. Um, Atherosclerosis or calcification of blood vessels is a risk factor, as well as hypercoagulable states, principally things like hormonal therapy like estrogen. Sometimes patients who on their own are hypercoagulable due to some underlying genetic abnormality, or patients who have prolonged hypotension for whatever reason can develop gut ischemia, particularly if the blood supply to the GI tract is not great to begin with. So how about symptomatology? Key thing for this is um, patients tend to have pain out of proportion to their abdominal exam. They are very uncomfortable. They may be screaming in pain, but if you check their belly, it might be soft. It may not be distended. You're just unimpressed by their abdominal exam. These patients typically develop what we call peritoneal signs with the guarding and the tenderness late in the course of their illness. So if you have a patient who has pain that's abdominal pain that's out of proportion to what you find in an abdominal exam, think about abdominal ischemia. Again, these patients have a high mortality rate of 60 to 80%. Diagnosis, how do we figure that out? Well, again, suspicion is the first thing. For us in the emergency department, any patient with atrial fibrillation and abdominal pain is at risk for acute mesenteric ischemia or gut that has an inadequate blood supply. So atrial fibrillation, particularly if the patient has pain out of proportion to exam, that's a good screening assessment. You don't need any tests to identify the patient as being high risk for mesenteric ischemia. Again, those peritoneal signs like guarding, rebound, significant distension come late. By the time those things are present, the patient's pretty much on their way to dying. We can get a further assessment by doing imaging, and really the procedure of choice is CT angiogram. It's quick. We can get it done. If I have a patient with we're concerned about mesenteric ischemia, I'll call the CT tech and said I'll tell them I need this patient to be next one on the table, and we will get those images done. We can do lactate as a screening test. It is a sensitive test, but it's not very specific, meaning if the serum lactate is normal, it's not likely the patient has ischemic gut. If it is elevated, it means it's more likely, but it doesn't mean it's definitive. It means we have to think harder and work harder to verify there is no gut ischemia. So how might we do that? Again, we do it with CT. So here are some images. If you look at the big red arrow on the left-hand side, you can see that there's a dark spot in that artery that's coming out of the aorta. So the aorta is up against the spine. It's grayish in color. It's got contrast in it. You can see that other vessel arcing off to the left. That is a superior mesenteric artery. And then you see, it goes from having a nice size caliber to there's just a big dark spot. That's a blood clot within the SMA. This patient has occlusion. And if you look at the central CT, you can see the white arrow that shows the blood vessel. If you look at that blood vessel, again, this is the SMA or superior mesenteric artery. There's a dark spot in the middle. That's blood clot. You have some lumen and dye going around it. So this patient has a blood clot that needs to be managed. So how do we do that? Well, if it's arterial occlusion, they go to the OR for treatment. If it's venous, which sometimes happen, we put them on anticoagulants, treat them medically. They don't go to the OR. The vast majority of the patients are acute arterial occlusion and need surgery. Last thing is acute arterial occlusion. So we're talking about blood clots. We talked for the other conditions like ischemic gut. We talked about embolic disease. There's something wrong with the heart. If blood clots form somewhere, it drifts out into the arterial circulation. It stops somewhere. For arterial occlusion, it stops in one of the arteries. If we're talking about acute arterial occlusion of the extremities, we're talking about a blood clot goes out, and depending on how big it is, it's going to get pushed out as far as it'll go, and then acutely occludes the artery. And typically we see it in the lower extremities more than the upper extremities, but it can happen in the upper extremities. We are not talking about deep venous thrombosis. We're talking about acute arterial occlusion, and there's a clot there. These patients typically have ischemia, and they can be very uncomfortable, and they often have history of peripheral vascular disease. So they have some narrowing of the arteries, and now they have an occlusion on top of it. Just like mesenteric ischemia of the gut, atrial fibrillation or valve disease of the heart can predispose or increase your risk for this. Atherosclerosis or narrowing of the arteries also increases your risk because it would take less of a clot to cause obstruction. And then patients with hypercoagulable state can also develop blood clots that can cause limb ischemia. Just like patients with hypercoagulable state are more likely to develop DVT in the legs and pulmonary embolism. So what kind of symptoms might you see? Well, think about the 5 Ps. So if a patient has an extremity and they have pain in it, it looks pale, you try to check for pulses and you don't find anything, or if you have the fortunate ability of having a Doppler and you listen, you can't hear a pulse. Or if you have numbness, so that's so bad that now they have a numb extremity. They may have progressed so far that now they have muscle death and develop some paralysis. Or maybe not totally paralyzed, but if you haven't moved their foot or toe up or down or against resistance, it hurts. And the foot may also look cold or poikilothermic, meaning no temperature or low temperature. So actually, I have 6 things here, but I call them 5 Ps. It's 6 Ps: pain, pallor, pulselessness, paresthesias or numbness, paralysis or pain with movement, and poikilothermia or a cold foot. Complications are limb loss. If it gets so bad and goes on long enough, they will have significant ischemia of the muscle, and they may get severely acidotic and may need to have an amputation in order to save their life. If they don't need an amputation, they can actually develop scarring and contractures of the muscles. The limb can become non-mobile and basically useless, and you can have skin breakdown or skin necrosis. How do we diagnose this? Exam. Again, think of the 6 Ps: pain, pallor, pulselessness, paresthesias, paralysis, and poikilothermia. We can get an ultrasound. We can do a CT angiogram, or we can do a standard angiogram, which is done actually by a vascular surgeon or a radiologist. For most of us, if we really think about acute limb ischemia, we've got a clot in the blood vessel, we will either do a CTA and then call vascular surgery, or we'll call vascular surgery immediately and say, hey, I got this. Do you want to take them to the OR and do an angiogram, or do you want me to CT them first? They will come in and see these patients any time of day. Actually, and how do we treat this? We treat this with anticoagulants. Looks like I got my slides out of order. So here's a. I'm sorry about that. If you look at the CTs again, this is CT angiogram. On the left-hand side, the white arrow, you can see that there's no white vessel going through there. There's no dye. That's an exclusion. Occlusion. On the right-hand side with the red arrows, you can see that you see these white columns of dye, and then they just end. What's nice about these images is you have the right leg, which is normal. You have blood vessels you can compare to. So look for the arrows. Compare it to the other side. You can see where there's a problem. So how do we manage these cases? Again, early suspicion and recognition. We anticoagulate the patients. We don't wait for imaging. If I think the patient's got an acute ischemic limb, I'll get the workup started, but I'll also start on intravenous heparin, which is an anticoagulant, and I will get the vascular surgeon on the phone quickly. I won't wait 2 hours for my workup to be done. I will get the patient anticoagulated. I will talk to the vascular surgeon. I will probably order a CT angiogram unless the surgeon says, don't worry about it, I'm coming in, we'll take the patient to angiography. But I will get them anticoagulated and I'll get the wheels started quickly. So thinking about 3 cases. So a 45-year-old female complained of acute left eye discomfort with drooping eyelid, mild headache, and right arm weakness. This sounds like a carotid dissection to me. She's got some discomfort in the eye. She's got a droopy eyelid, which could be part of Horner's. She's got a headache, which could be a symptom, and she may be developing stroke symptoms because the left side of the brain may be involved, giving her right arm symptoms. So this patient, from my perspective, is a carotid dissection until proven otherwise. The 30-year-old with Marfan's, we talked about Marfan's with the risk factors for aortic dissection. This patient comes in with acute chest pain radiating to the upper back or the interscapular area, and they've got bloody diarrhea. So this patient could have an acute aortic dissection. It could be going far enough down that it's interfering with the blood supply to the gut. And now the gut is also suffering and the patient developing bloody diarrhea as a complication. So from my perspective, this patient with Marfan's has an aortic dissection until proven otherwise. And then the third case is 75-year-old female, severe abdominal pain, irregular pulse and minimal abdominal tenderness. This patient is an irregular pulse. You don't need a 12 lead or a 4 lead to tell you the patient's in atrial fibrillation. Who knows how long she's been in it? She now has severe abdominal pain, but you check her belly and it's not very tender. This patient's got ischemic gut until proven otherwise. This patient needs transform. All right. So in summary, all the things we talked about are bad. There's no upside to any of them unless you have a high level of suspicion and get the patient to care quickly. Examine the patient. So if you have a patient with abdominal pain, lift the shirt up, take a look, see what it looks like. Do they have symptoms concerning for ischemia? If the patient is complaining foot pain, leg pain, and of abrupt onset, take off the shoe. If necessary, take the pants off. Take a look at the leg, compare one side to the other. Is it cold? Is it numb? Does it hurt to move? Does the patient have a pulse? Look at the body parts of concern and notify the emergency department of your concern even before you come in as part of your radio report. I've got a 75-year-old female with atrial fibrillation, severe abdominal pain. I'm concerned she might have an ischemic gut. Or I have a patient with acute leg pain. The leg is pale, cold, and has no sensation. I'm concerned about a blood clot in the artery or acute arterial occlusion. So examine the patient and pass your concerns on to the receiving facility. So that's it. Hopefully I've covered things well. Again, my apologies for messing up the titling of the ischemic limb and getting a couple slides out of order, but hopefully the message came across. If you have any questions, please let me know. Thank you.